In this session, we're going to look at the subjective examination of the lumbar spine. And we're really looking at it in terms of the value of the subjective examination. For a lot of people, the subjective examination is nothing more than just asking questions. I mean, isn't that all that you really do? Isn't it just a matter of just asking patients stuff so that you can fill in the front of their chart, so that you can find out, just a little bit of background information before you really get into the most important part of the assessment, the most important part of the evaluation being the objective. It's really when we get to the tests and measures that's when we really can understand what's going on with the patient. Well, hopefully today we can show you that that's not exactly the case. That your subjective evaluation is as important, if not in some cases more important, than your objective evaluation. That your subjective evaluation, if done properly, will really steer you and direct you when it comes to the objective evaluation. So that whenever you do get those tests and measures, when you do start doing those movement tests with the patient, you know what you're going to see because you've already asked all the questions. You've already heard from the patient and you understand their condition. And so the subjective is not just a matter of asking questions, but it's about getting what you want to know and then directing your objective evaluation. So today we're going to rethink the subjective. We're going to identify the component parts. We're going to talk about those component parts. We're going to look at each one individually, maybe delve a little deeper than you had previously thought about. We're going to maybe take some time and plan a subjective assessment. And then we're going to prepare ourselves for the lab session. So, here's a statement for you to consider. If you don't know what you're going to treat, how can you expect to be effective with your treatment? If you have a patient sitting before you and you don't know what you're going to treat, how can we ever expect to be effective with the treatment that we do perform? Is it just guesswork? Or is there something more to that? When it comes to evaluating our patients and actually talking with our patients, then the first thing that we do is we ask them a series of questions. And we can't separate questioning from the subjective, but we've got to consider it as being more than simple questioning. And in the subjective, in our questioning, we're looking to gain information from the questions that we ask. We're also looking to gain information from how the patient answers the question. It's not just the answer that's important, but it's how the patient answers it that is equally as important. And so when we're involved in our subjective evaluation, we need to be focused on our patient. Don't be trying to do two things mentally at once. Don't be trying to process what you just did with your previous patient whilst you've got this new patient in front of you. We've got to listen for how they respond and not just listen for what they respond with. We also, through our questioning and through our discussion initially with our patient, we want to allow our patients to really get comfortable with us. If your patient is comfortable with you as a therapist, if they have confidence in you as a therapist, then they're going to trust you. They're going to trust what you say. They're going to follow what you ask them to do. And your treatment is going to be so much more successful just because they have confidence. But if they don't gain any confidence, if they don't feel that they're being heard, if they don't feel that you're really focusing on them, then they're not going to trust what you say. And they're more than likely not going to do what you say. Which means even if you tell them to do the most accurate thing, the most correct thing that they could do, they won't do it. And it's just because of trust. It's just because of the questions. Now, there's a little problem that comes along with questioning. A couple of problems that come along with questioning is the language. A number of times the things that we ask may not be what the patient heard. You ever had that situation where you've asked somebody something and they've given you a completely random answer? Because what you asked them is not what they heard. Most of those instances that we have is typically because the person isn't listening to us. But our patients are listening to us. But still, they don't understand the terminology. They don't understand the words and the language that we use. And so what they give us back is not what we asked them. Have you ever had that patient that answers with the answer that they think you want to hear? where you ask them a question and they give you that answer because they think that's what you're expecting them to say? A lot of times, maybe not in our initial evaluations, but we ask questions to our patients like, does that feel better now? Or are you feeling better today? Where the kind of the question itself leads the patient to a yes response. Because a yes response is an affirming response for us. It's a positive response for us. The patient says, oh yes, I'm feeling great. Even if they're not, then we will feel better because we'll think that our treatment has been effective. But if the patient isn't feeling better, we want to know that they're not feeling better. And so hopefully we will get answers that we want, not the answers that the patient thinks that we want. And we want the truth. Have you ever been in those situations where you ask too many questions and you don't actually allow the patient time to answer? Where we just question them one thing after another. A lot of times whenever we're new therapists or new into the profession and we're a bit nervous, then we just ask a number of questions and the patient hasn't had time to respond and they're not sure which one to answer first. Let's go with the one question, one response approach. Let's not ask our patients too many things at one time. Another problem that occurs often with questioning is when the patient doesn't understand. Just saying the question a little slower and a little louder doesn't actually help with their comprehension. When a patient doesn't understand, it's because they didn't understand, not because they didn't hear. And so when a patient says that they don't understand or they have a puzzled or confused look on their face, don't just say the question slower and louder, but rephrase the question. Reconsider the question in your head. What did I just ask? How did that... Oh, no much wonder it was confusing. I used these words. They don't know those terms. So what about this? And you ask the question in a different way, and then you get the response that you're looking for. So there are problems with questions, but we can address those problems before our patients even come into the clinic. In all of this, we have a huge responsibility. Our patients come to us as healthcare practitioners who can help them. We have the skills and the ability to help them, and they need our help. But our patients don't speak our language. Even if they've gone on to WebMD and they come in armed to the teeth with everything that the internet says about their condition, they don't understand the terminology in the same way that we understand the terminology. There are words that we use that are just weird to other people. If I were to say abduction, well, to a room full of physical therapists, to move into abduction, people understand that. But you talk to lay people or people who aren't in our profession, and they're wondering, why are you spelling the first two letters and then saying the last part? Well, it's our differentiation from adduction. And so things like that, simple things like that, that we use every day, we've got to be mindful of. We've got to be careful of when it comes to questioning and talking with our patients. We should also speak slowly. Ask short questions. Make the questions easy to answer. There's no limit on the number of questions you can ask. There's not like you've only got 20 questions and that's it. You can ask as many questions as you need to ask, and your patient will give you the answers to each one of those. But by building up a small bank of questions so that we have these questions that we ask that are easily understood, that are easy for the patient to give us the information that's valuable and vital to us, then that's going to be really helpful. So as we consider our questions and we consider the subjective examination, just think about how you do it. When you go to the next patient that you have, consider the subjective evaluation. Consider the questions that you bring. Are you just there rushing through the subjective to try and get to the objective? Or maybe you could take some time and actually use the subjective examination to get a lot more useful information. Okay, the components of the subjective examination that we're going to look at: the nature and the kind of the disorder, the history, both present and past, we're going to consider that, the site of the symptoms that the patient is complaining of, the behavior of those symptoms, any special questions, and then we want to hear the patient's perception of their injury. This questioning is all about hearing their side of the story. When we get objectively into testing things, then we'll hear the structures side of the story. So let's look at the kind of the disorder. When it comes to our patients, we've got to identify what they consider to be the main problem. Not what we consider to be the main problem, but what they consider to be the main problem. Because that thing will be the thing that will limit them the most. And we might be treating one aspect of the condition, thinking for us that, well, clinically, that is the most important thing. But if it doesn't affect what the patient believes to be the most important thing, then the patient won't think our treatment is effective at all. And so we've got to ascertain from them their main problem. We want to ask the patient questions like, well, what can you do? What would you like to do? What does this condition stop you from doing? We want to ask them questions about pain. So the pain that you have, what does that pain stop you from doing? Or stiffness. They may have a sensation, a tingling sensation or a numbness down into the back or into the legs. So how does that affect them? How does that affect their daily life? We want to look at their history. We want to ask the patient, what happened? What happened at this time for this condition? Now, the thing about the history is that you don't have to ask that first. You can actually take the history at any point during the evaluation, but a lot of times we start with it. A lot of times we want to get the picture. We want to know what happened to get you from where you were into my clinic right now. We want to find out their story. We want to find out their version of the story. A lot of times when we hear their story, that actually then directs us into the rest of our subjective evaluation. That their question, their story, their relaying of what happened, the direction of impact, the nature of the condition, the type of injury that they sustained. That will then guide us or lead us into further questioning. Most importantly, we want to identify the history of the present condition or the presenting episode of this condition. We are interested in their past history, but we're not that interested in their past history. And that can sound a bit crass, but when we ask our patient what happened, we want to know what happened within the past 2 weeks, 3 weeks, whatever it was, 3 months, whenever the original injury was, what happened at that time to bring you here. We don't want to have the whole list of their medical chart from the time when they fell out of a tree when they were 6 and they broke their arm and it just led to this and this and this. We don't need all that background information. If at some point in your discussion and some point in your examination you find something abnormal, then you might want to ask, did you ever hurt this other structure? But right then, we want to know, what did you do to this structure? When did you do it? What happened? So we're looking for the present history. And it could be the present history of the condition or the present history of the episode. If someone has had back pain, an ongoing back pain for a number of years, but they've had 6 months where they've been pain-free, and they're back in the clinic because something happened, there was an incident that took place which then triggered this latest episode. We don't really need the whole 2-year history. What we need is the present history. What was the trigger that brought you in at this point? What happened? Questions like that. When did it happen? How many times has it happened? All these types of things we want to know. When was the last episode prior to this one, or is this the first one? Is there a repetition? Have they had this before? Are there any precipitating factors? Any details? Are there any predisposing factors? Has there been any progression, either better or worse, since the onset? So if the injury occurred 3 months ago, well, has it occurred before? No. First time. Okay. Has there been any change? Has it been getting gradually worse? Has it been getting gradually better? Has it just been staying the same the whole time? Oh, okay, so it's been getting worse. All right. So initially then, you probably didn't do any treatment. No, because at the time of injury, this is what happened, and I didn't think it was that bad, so I thought it would go away, so I didn't do anything for 4 weeks. And here we are, 8 weeks later, it's getting worse, and I've finally come to address it. Well, in that, you've identified that this was an acute condition, but it's now moved into the subacute, possibly the chronic stage, and the patient hasn't really done anything that would have helped to treat it. Ask our questions. If we do need to go into the past history, then the key thing that's important about the past history is any previous physical therapy. Have they had treatment on this condition before? And if they had, was it effective? Was it not effective? It doesn't matter who did it. Don't get into that. Don't ever ask who the therapist was. Because what you want to know is not who, but what. Well, what did they do? Did they give you a home exercise program? Yes, they gave you a home exercise program. Did you follow it? No. Okay. Compliance issues. We're gaining information. We're gathering information from our patients. We're filing it away for future use. If they did have treatment, how often? Did they go twice a week, 3 times a week, once? Did they have one treatment session? It wasn't effective, they never went back? We want to identify all of those different things. We want to understand the extent of the recovery. So from that previous episode, did you completely become pain-free? Were you able to go back to your job or your daily activities? Okay. What happened to lead to this next episode? So we want to know the extent of the recovery. We want to know progression over time. We want to know is it getting worse? Are the episodes getting worse or more intense? Or is there an episode, then a recovery, then an episode, then a recovery? And what's triggering those episodes? Is there any other related disorder that could be part of the problem here? Don't assume anything. Always clarify. Don't assume that just because the patient says one thing, that's what they mean. If the patient can mishear us, if the patient can answer our questions based upon what they've heard, then make sure that you're hearing what the patient is saying. Don't assume. Always clarify. We need to consider the site of the symptoms. We want to think about the specific location of each of the symptoms that the patient is complaining about. If it's pain, where? Where is it painful? What's the most painful part? If it's stiffness, again, where? When? How often? Dig in. Don't just ask, is it present, but delve into why is it present? How often is it present for? Our questions have got to go to that second and that third level. We can't just stop at those initial, does it exist and does it not? We've got to delve a little deeper. We need to identify the depth and the nature and the behavior of the symptoms. We can't do that with just 1 or 2 questions. We've got to dig a little bit. We also can take and record our signs and symptoms and record the patient information on body charts. Begin to create a body chart where you've identified the pain, the stiffness, the tingling, the loss of sensation, the strength or the weaknesses, so that whenever we look at that picture, we can see clearly where the symptoms lie. That will be really helpful for us when it comes to identifying and leading into our objective examination. We want to look at the area and the depth of referred pain. So they have this pain. A lot of times patients come in with they'll come in with back pain across here, and it just goes down this leg. Well, how far? Does it go all the way to the heel? Is it just to the buttock? Is it down into the knee? Is it a deep feeling? Does it feel superficial? What's the nature of it? Ask, dig a little deeper. Consider your dermatomes. We'll talk about those in a moment. Consider myotomes. Where is the pain running? Is it following a particular pattern? We want to identify the original area of onset and then the spread. So did the pain originate in the back and then spread to the legs? Or did the pain begin in the legs and spread up to the back? Which way did it go? Did it just originate in the back and it's just spread, it's just stayed there? Identify the original area and the onset. And then finally, with the site of symptoms, we need to make sure that the site of the symptoms is actually the location of the cause of the symptoms. If somebody has low back pain, well, that could be a localized problem, or it could be a referred pain issue. If somebody has pain in the buttock, well, that could be a localized problem through hip joint issues, muscle issues, or it could be a referred pain problem from the low back. We've got to be able to clear the joints above and below so that we know that there's no referral going on, that the location of the symptoms and the site of the symptoms is coming from those structures and not from something distally referring into that location. I mentioned body charts. There's lots of body charts available, lots of different styles of body charts. Get those anterior, posterior views, just of the little man standing. And begin to shade in. Okay, so they've got low back pain. So you start to shade across the lower back. P1, intermittent pain, 6 out of 10. When you pick up that picture, and if you've never seen that patient, you've never met the patient, but you pick up that picture and you see that little diagram with a shaded in area across the low back which says P1, okay, so their most intense pain, and it's 6 out of 10, and it's intermittent, then you know a lot of information about that patient already. But if you're having to read through a paragraph full of notes to try and identify where's the pain, where does it hurt, then you're going to miss a lot. If you have that same patient with that low back pain shaded in, and then there's another shading that goes down the leg, and it says P2, 4 out of 10, then you know that they've got this intense low back pain of 6 out of 10. It's intermittent. But then they've got this other pain that goes down into the buttock or down into the leg. And that's their secondary pain. All from a picture. All from your questions. We want to consider dermatomes. When you see those body charts, is that pain pattern, is that direction of that radiating pain following a specific dermatome? I've got a dermatome chart here. Okay? Are we dealing with L1 or L2? L3, 4 coming across, 5 down into the big toe. What's it going to be? Now, I know that depending upon the dermatome chart that you've got, there's slight variations. But are we right on the edge between L5 and 4? If it's down in here, it's not going to be an L3 and L2 issue. It's got to be an L5, L4 issue. Even if you can't differentiate, is it one or the other? If it's above the knee on the anterior aspect of the thigh, L2 or L3. Ask the questions. Fill in your body charts. Draw those lines in there. Shade in so that your colleagues can pick up your charts and see exactly what's going on. There are lots of dermatome charts available. Lots of different variations. Use whichever one you're most comfortable with. But let's use them. Let's use them to share information on our patients. Let's use them to take notes of our subjective examination so that whenever we take those questions and we filter that information, we translate that information onto the human form so that we can understand what's going on. We also want to consider the behavior of the symptoms. We want to consider changes in symptoms. So we want to ask our patients, where does it hurt? And they tell us. We then want to, as we go through different motions or we ask them about different activities, does that change your symptoms? So you've got low back pain, yes. Does it hurt when you lie down? No. So it changes. Does it hurt when you bend over? Yes. So it changes. It intensifies. Or it diminishes. We want to ask those questions, so we ask them a series of questions dealing with body position, extension, patient stands up, patient walks, The lumbar spine's put into extension. Does that cause an increase in your pain or a decrease in your pain? Does it cause an increase in your pain or a decrease in your pain when you bend over? When you sit down? When you lie down? All of these different motions, all of these different movements that can aggravate or can decrease or ease their symptoms. We want to differentiate between localized pain and referred pain. So we want to differentiate between the pain that they experience in the low back and the pain that they experience that's radiated down the leg. The questions that we ask and the understanding of location, the path or travel of pain, the understanding that we have of where it sits in regards to our dermatomes will really help us as we plan and get ready for our objective evaluation. When it comes to asking questions, we're going to ask a number of questions about pain or stiffness that really are similar. And so let's just deal with pain. You have pain. What makes it worse? Now, if you just ask that question, the patient might say, I don't really know. Or they might have one thing. But you need to have a list of things. You need to have a list of motions or movements that you can recite so that your patient can go yes, no, yes, no. So what makes it worse? What's your aggravating factors? What about walking? Walking's extension. What about sitting? Sitting is flexion. What about standing? Standing is extension. What about bending over or stooping? Again, flexion. Twisting, rotation. Lying down, could be either extension or flexion. Now, when we ask those questions, we're not really that interested in what the positions that they can get into, but we're interested in, does extension cause your problem to increase or decrease? Does flexion cause your problem to increase or decrease? What's aggravating it? Is it an extension issue where we're looking at compression of a facet joint maybe? Or is it a flexion issue where we're maybe looking at the bulging and the protrusion of a disc? What makes it better? All of those things, again, does that make it better? Does that take the pain away? Does that decrease the pain? What's it like over 24 hours? So first thing in the morning when you get out of bed, do you have pain? Yes, no. Does it get worse? Does it get better? What is it? What's it like then at lunchtime? What's it like then during the afternoon? Or what's it like at night? Does it intensify at nighttime? What is it? I have a model of a spine here. Let's just take you through your normal day. Let me just click all the things. So we're going to ask our patients, well, what happens during the day? What do you do during your day? And here's our typical day. We start off, and we all sleep. And some of us sleep nice and straight. Some of us sleep really curved, really bent. And we get up in the morning, and we're not really morning people. And so we trundle our way into the bathroom. A little bit of a problem there. We trundle our way into the bathroom. And we look in the mirror. Oh, it's just too painful. And we get ourselves organized, and we go downstairs, and we sit down, and we turn the TV on, and we check what's going on in the news. We want to make sure our ride to work's going to be okay. And so we go back upstairs again, and we get ourselves dressed, and we sit in our car. And because we live in the metro area, we sit in our car for a long time. And we're still sitting in our car. And gradually, our normal curve changes. And we end up in this flex position. And so we're sitting, and then we get into work. And we sit at our desk. And we just push paper from one side of the desk to the other. until it's time to go home. And then we get back into our car, and we sit in our car, and we sit, and we sit, and we sit, and eventually we get home. And then what do? Well, we sit on the sofa, and it's Monday night, so we watch the game. Flexion in sitting. Extension in standing. Extension in walking. Flexion while bending. Or rotation. These are the motions that we want to find out from our patients. These are the motions that we want to see. Are they aggravating or are they easing? Because everybody goes through those motions each day. We want to look at the pain level at night. Do you wake at night because of pain? If so, how often? How many times a night do you waken? And how many nights a week do you waken? We're going to ask, is this pain constant or intermittent? A lot of times patients will say it's a constant pain. It's always there. It never goes away. Well, that's not always the case. Because if you just ask them about their easing factors, does it feel better when you lie down? Yes, it does. Does it go away? Yes, it does. Is it constant or intermittent? It's constant. But hang on a minute. Didn't you just say that it went away when you lay down? Well, it does. Well, then it can't be constant. Constant pain is a constant pain, always there, 24/7, never relenting. Constant pain usually signifies quite a sinister condition, quite a serious condition. Majority of our patients will have intermittent pain. Majority of the cases that we will see. We want to identify or try and measure that pain through tests like the visual analog scale. Get that 10 centimeter line marked. Put it beside your body chart. Where 0 is no pain, 10 is the worst pain that they've ever experienced. And get them to mark a line on it. Or get them to give you a number between 0 and 10. Some form of measure that your patient can give you to give you a little bit of objectivity to that most subjective of assessments. We need to consider the irritability. So we need to ask the patient all these questions, and in the process of gaining those answers, we're considering, is this an irritable condition or a non-irritable condition? Is this a condition where if I push them too hard, it's going to shoot their symptoms up? It's going to take a long time for those symptoms to recover, and so I'm not going to be able to do a lot of treatment? Or is this a situation where they're not that irritable? The condition isn't that irritable. I can actually probably do a lot with them before I cause an increase in their symptoms. And so I could push them a bit further. We've got to assess irritability. We want to identify any activities that provoke pain so that we might leave those to the end of the assessment, our objective assessment. We might do the ones that are non-provoking just to see how the body responds. In all of our questioning, we want to ask our patients, well, okay, when you do these activities, does it take a long time for it to settle? So if you go for a walk and you can walk, 1 mile, and in that 1 mile, your back pain intensifies from 3 out of 10 to 8 out of 10. When you come home and you sit down, because flexion is a more comfortable position, how long does it take for that 8 out of 10 pain to settle back to that 3 out of 10 pain? What's the difference? What's that time frame? That will give us a measure of irritability. And so we want to assess that. There are a number of special questions that we must ask because we don't want to put our patients at risk from some of the more aggressive tests that we do. We want to be region-specific with those questions. There are special questions for the neck, special questions for the knee, special questions for the back. General health is one of the questions that we should ask. Are they generally healthy? Do they have this malaise? Have they been, fighting against the flu symptoms for a long period of time? Is their body in some sort of fight against infection, which is decreasing their ability to heal? Are there any red flags? Are there any contraindications or precautions that come from their general health? from their nutrition status. We want to ask about things like bladder and bowel. Do they have frequency of going to the bathroom? Do they have an urgency about going to the bathroom? They notice that they've been going a number more times a day than they used to. Are they showing any signs of cord compression, upper motor neuron disease, any of the things like that? We want to ask about the vertebrobasilar artery and any insufficiency, any tingling, any ringing in the ears that they've had. We want to try and find out about that. We want to ask our patients about osteoporosis, particularly our female patients. Have they had osteoporosis? Have they been diagnosed with that before? Because we don't want to go in and try and do a lot of mobilization on a patient who's got osteoporotic bones. We'll end up causing fracture and further damage. We want to ask them if they've had any special tests done, any MRIs or any x-rays. We're not going to go completely on the findings of those, but we're going to incorporate the findings of those as part of our assessment. We're going to ask them about any diagnosis that they've been given, or any explanations that they've been given by their doctor about the condition. We want to ask them if there's a history of arthritis in the family. Is this the precursor, this current episode, the beginnings of what will potentially become a debilitating disease process? So we want to ask about those things. Now, when it comes to questioning, we've got to think about how we question. And this kind of sounds a little bit simple and a little bit obvious, but if you've ever listened to somebody do an evaluation of a patient, there's questions that they'd ask, and you'll think to yourself, I would never ask that in that way. I would never have put that in that sort of sentence structure. I would never have said that. I wonder why they said that. And so I want to just take a little bit of time to think about questioning and think about questioning techniques. I've talked about some of this stuff, so I'm going to use it as a recap for this session. When it comes to questions, we want to make sure that we're using our patient's language, or a language that the patient can understand. And I don't mean Spanish or English or French or German or something like that. What I mean is that the terminology that we use is terminology that is normal for the patient. So we ask our patients to walk in. Just walk across the clinic so that you can see them walk. Don't ask them to ambulate, because we use that term, but most patients don't. Don't ask them to elevate their shoulders through flexion. They don't understand what that means. Raise your arms above your head. They understand that. So let's use their language. Let's use words that our patients understand and not just our own terminology. Ask non-biased and non-leading questions. When you think about a question, don't give a question where it's obvious that the answer that you're looking for is a particular thing. Because the patients will give you that particular thing. You're just steering them. Ask non-biased, non-leading questions. You want to ensure that your questions are sincerely stated. Have you ever been in a situation where somebody's been asking you questions and they don't look at you? Where all that you see is the top of their head because they're taking down notes or they're writing down whatever you say, and they never glance up, they never look at you, and they never engage you in eye contact. How did you feel? Did you feel that the person was sincere, that they were really interested in what they were asking you? Or did you just feel like they were just getting information that they had to get? A lot of times our patients feel that we're just getting information that we have to get. That we don't actually care because we're not making that eye contact. And so we've got to lift our heads and ask our questions to the patient and then take a moment to jot down our notes. So let's be sincere as we ask our questions. Where possible, try and just elicit one-word answers. Don't ask open-ended questions that let your patient just go on and on and on and on, because some people will do that. And you'll look at your watch and 35, 40 minutes has gone by and you still haven't got through the history of their condition. So one-word answers. Keep it brief. If needs be, use comparative questions. So this versus this. Is it more painful when you do this or when you do this? Is it easier to do this or do this? So use those comparisons. And ensure always that your questions are clearly phrased. When you hear the patient's story and you start to make an idea or form an idea as to what you think is wrong, your questions then will be based upon your hypothesis. As you begin to think that it sounds like it's more of a discogenic issue, then you'll begin to ask questions that will either accept and acknowledge that yes, it is a discogenic problem, or they'll begin to refute that. And so allow your hypothesis to steer your questioning. Allow your questions to confirm or modify your hypothesis, so that we're constantly reasoning our way through the case and not just going through a list of pre-prepared questions. That would be the worst. Just to ask a list of things to get the answers, to never have thought, what do these answers actually mean? The other thing which I want to encourage you to do as you're going through your subjective evaluation is listen for spontaneous things. Not information that you've asked for, but spontaneous information that your patient gives you. Because that can sometimes give you a better indication as to the true nature of the condition. I've had instances in the past where I've had patients who have come in and they're in the clinic because of there's been an accident of some description, and they are there to be treated for some ailment. But in the process of just talking with them, they have confided in me or told me stories about how they're renovating their home, or they're doing this outside work with their condition that they're complaining of should actually be problematic. And it makes me wonder. So I've asked you the questions and you've given me the answers, but are those answers really true answers? And now you've just let this little piece of information slide out in conversation that you're doing this additional work when you shouldn't really be able to do that work based upon the findings of what I've got in my examination. And so I heard something and was able then to ask a little further to identify whether or not the answers that I had received earlier were actually true answers. So listen for spontaneous comments and spontaneous remarks. Through all of your subjective, you want to get the patient's point of view. You want to almost get inside of their skin so that you know what they feel, what they think, you know their experience to that point, and you've got a better understanding as to how you're going to make a difference. You know what their fears are, you know what their concerns are, you know what causes their pain, what takes their pain away. Because when you really have that rounded understanding of their perspective, then we're going to be able to treat them and involve them in the treatment, and we're going to get our patients back to where they should be. Ask questions like, as far as you're concerned, what's the main problem? From your point of view, what do you see as the main issue here? So involve them, get their understanding, their clarification of the symptoms. We discussed the present history earlier. If there's an identifiable cause, dig in around that. Question that even further. Make sure that in the cause and the description of the cause of the injury that you can identify the mechanism of the injury. Don't just be satisfied with it was a road traffic accident. Well, what type of road traffic accident? Were you driving? Because that will then change the position if they're holding the steering wheel as compared to if they're the passenger seat. Were you hit from the side, the front, the back? Because that will again change the force of the impact or the direction of the force. That will also then change some of the biomechanics of and the mechanism of the injury. So don't just write down road traffic accident, but rear collision, side collision, driver's side, passenger side. Identify further. Ask those second and third level questions to give you all the information that you need. If they don't have an incident, I don't know when it started. It just kind of started. It just kind of started to hurt, and I don't know why. Go back a little bit. What were they doing? What were they doing the weeks before that? Did they change anything? Did they buy a new bed? Think laterally. Did they do something that they don't even think is related? But whenever they tell you, oh, that's what you were doing. That's why. And it all fits in. When we identify symptoms, we want to be clear about where. We want to be clear about how much. We want to be clear about what makes it worse and what makes it better. We want to make sure that we are fully on board and fully understanding our patient's perception of this condition. And if we're unsure, ask and ask. And so we take our subjective examination, and instead of just being this short little question time, where we just get their name and their doctor and a little bit about the history, a little bit about the injury, and okay, let's actually start doing some objective measures. No, our subjective then becomes a real dig into their history of this condition, the incident, what happened, all aspects of it, their perception of their condition. It becomes a time when we create that hypothesis, and we, as question comes in and answer comes back, that we are really affirming our hypothesis. So by the time we come to do our objective examination, we pretty much know what we're going to see. By the time we come to get our patient to move, we know what's going to hurt. We know what's going to be pain-free. We know how hard we can push them. We know where we have to hold back. Because we've taken the time to ask questions and questions and questions. We've taken the time to really use our subjective examination to its most effective. During the treatment sessions, then, because we've asked so many questions, because we've elicited feedback, when we get into treatment, our patients will feel comfortable and confident in giving us feedback and telling us things. Our patients will not be shy about saying, that hurts, that doesn't hurt, because we've included them in the conversation. And so we're going to find with our subjective, when we do our subjective well, that it actually helps in the rest of our treatment sessions. When we take all of the information that we've been given and we put it all together, we should have a picture, a mental image of what is wrong with that patient. We should be almost 80 to 90% certain of what we're going to find objectively. And that then guides us and directs us so that we know where to go with our objective examination. I hope that in considering this, in terms of your subjective, that when you come to your patients, that you'll begin to challenge yourself. Begin to challenge yourself to think, can I have a hypothesis just from my subjective evaluation that I can then operate off of through the rest of my evaluation and assessment? Don't just be satisfied with just asking a few questions. Expect that at the end of your subjective evaluation that you know what's wrong. And expect that your objective evaluation is really there to confirm what you've believed because of your subjective. When you begin to do that, then you truly are clinical reasoning. You truly are hearing information, getting data, evaluating and analyzing that data, and then utilizing that data in your objective. If you have any questions about subjective examination, please email them to me at jason.craig@marymount.edu, or bring them with you to our lab session and we'll discuss those questions then. This is the subjective examination. I want to encourage you to check out the other videos that we have available on the objective examination and then on Maitland's philosophy of treatment as well. Thank you.